fundamentally do not change because people care. They change because the rules change. You can't force through a policy that's immediately going to get overturned because everybody hates it, right? It's not just about that policy win, it's about building the community and shifting the Overton window. Let's accompany ministers and connect them with something that inspires them, with people who can bring their vision to life. Let's activate community health workers and connect them with not just a neighboring community health worker, but with the whole history that they're part of. Like, it's about connecting to the mission and connecting to each other, that we're moving down the field together.
Hey everybody, I am delighted to be joined this week by Madeleine Ballard, and forgive me for reading some of this out loud from my notes, but Madeleine's incredible. She's the CEO of CHIC, which is the Community Health Impact Coalition, which is this global movement transforming healthcare by making community health workers the norm. Now, before I move on, there's a lot in Madeleine's intro here. I just want to say that it doesn't take a quantum computer to do innovation in healthcare, and that's what we're going to be talking about today. When we talk about global health, community health workers, and making that the norm, and making sure that they are equipped with basic data infrastructure, we're going to talk about today is one of, if not the most important global health innovation we can be focusing on now, and that is what Madeleine focuses on through the work at CHIC. Now, in terms of Madeleine's background, she's also driven policy changes that have increased the quality of care for millions, which again displays her innovation, because it's certainly an innovation to drive any policy change, let alone one that makes that level of impact, which I'm sure we'll go on to speak about. She's got a PhD from Oxford, Rhodes Scholar, faculty member at the Icahn School of Medicine. Am I saying that correctly? At Mount Sinai. She's featured in the New York Times, Forbes, Lancet, loads more of those. Scholar Award for Social Innovation, Rue Prize, Schwab Social Innovator of the Year. So much, Madeleine, and welcome to the Healthtech podcast. Delighted to have you. How are you?
Thank you so much, James. I'm great. Excited to be here.
There's loads that we can talk about, but what I first want to do is go through your background, because coming from a PhD and an academic side of things, and then turning that into the level of impact that you have, and uniquely and rarely for this podcast, not through building specifically a tech company as well. So can you start at the beginning for me and talk about your path to becoming a founder, a CEO, and an innovator in global health through everything that you did with academia and beyond?
Yeah, sure. So I think it's important to say that I grew up in Canada, and ended up going to university in the United States. And this was a pretty pivotal moment, in that when you grow up in Canada, it's kind of like growing up in the UK. You have a national health service, healthcare is a right, you don't think too much about it. But unlike the UK, in Canada, we kind of have that second country symptom where you're next to a superpower. So all you hear about your whole childhood is how this country is, richer, more powerful, more important in every possible respect. So it was a quite exciting prospect to go there. And then a bit of a letdown once I arrived, because it was like, wow, what is going on with healthcare in this country? Like,
Oh,
I'm not that old. This was like the 2000s.
yeah.
And there were still like waiting lists for HIV drugs at that point, and this is just as Barack Obama's getting elected.
Right.
He's talking about, AIDS-free generation. And it's like, you have people in Florida who can't get drugs right now today in your own country, And so it was really, I think, astonishing. And this was, for the technical among us, was right after the World Health Organization had kind of made this recommendation that as soon as you get infected with HIV, you should be on drugs. Because as the activists have long been saying, treatment equals prevention. If you're on antiretroviral drugs, like, this is just like having a lifelong chronic disease. You can't pass HIV on to other people. This is a wonderful and amazing, health tech innovation. Let's get it to the people. And so anyways, I ended up getting involved in kind of HIV activism. All of a sudden that opens up you up to like a whole globe, a whole transnational network of solidarity. People in South Africa, people in Sierra Leone, all fighting for this same thing, this
Mm.
access to the pill that turns HIV from an death sentence into, a little niggling thing that you take care of every day for about 5 minutes. And so, anyways, I ended up after university with some of those HIV activists in Liberia. Was living there for a couple of years, and it was kind of at the moment that they started to ask, "Hey, we're HIV positive." We returned to Liberia, which is a country in West Africa, which had a very long civil war in the 90s and early 2000s, about a decade. And they had, when Ellen Johnson Sirleaf, who you may have heard of, the first female president elected in Africa, got elected post-war. She kind of made the call back to the diaspora, come back, rebuild Liberia. And so these HIV activists got there and they were like, listen, like we're in rural South Asian Liberia. Like this is a country that has, 5 million people and 30 physicians after the war. Like if we wait for physicians in these rural areas, like we're just gonna die. We need the drugs right now.
Wow.
And because of the Global Fund, which is a big global health mechanism that helps countries get access to these drugs, Liberia actually had a ton of these, HIV drugs in a warehouse, and the question was, how do we get them out? And this group had basically, one time I joined them, just convinced the Ministry of Health, like, hey, we can use community networks. We can use non-physician clinicians to enroll people onto these drugs, and then community networks to keep them onto these drugs. Because sometimes, there's stigma, there's shame, there's the question of if you're not eating enough, it can be quite gastrointestinally intense, and so that kind of accompaniment is what makes the difference between people kind of staying on them and kind of giving up, or even starting them from a place of deep despair in the first place. And so I was kind of joining them at the moment where they were like, okay, we have this amazing network, which PS, you can look up the studies on this, like the alive and in care rate for people in rural Liberia with these community members was like triple the alive and in care rate for patients, in the capital in Liberia, in Monrovia with the doctors. And it was like, yeah, because that solidarity, that high touch point, going to find you, not waiting for you to come to the health system, all these things made a big difference. And I kind of joined them at the moment that they were beginning to ask, hey, HIV is our problem. Epidemiologically, though, it's malaria, it's pneumonia, it's diarrhea. That's what's killing people. How do we use these networks of care for more? Anyway, I'll stop there. But that was kind of the arc. That's where I first started to really live with, work with, and understand the power of community health workers, people who bring care to their neighbors' doorsteps.
Just on that, Madeline, I think it's it's so interesting for me actually. Now that
Sure.
I've seen a couple of waves of health tech, having been in this game for uh, a decade or two now, that we're we're only now in the West seem to be coming round to this idea of, oh, hold on a minute, it needs to be community, community, community. It's the most overused word, sorry, of the last like couple of years at least, I think, in tech, because we're sort of
Mm.
retrofitting this screen that sort of pseudo connects us to people, and we're sort of throwing this community word on top and going, oh, we can build communities. And it only seems to be since AI and LLMs specifically have taken off that people are now plotting a path to, oh, hold on, in the West, with all our resources, we could actually put humans next to each other and build community that way. We don't necessarily need to go through an app to do it. But it almost seems like rudimentary in our thinking here and quite clunky. Whereas, I don't know, what you've described just seems so human, and the answer and the results speak for themselves, in that it just seems so basic for us to think, well, if we just put a group of people together, then they're going to have an increase in adherence, and they're going to be able to understand their uh, symptoms and their side effects and all these things, and they get the solidarity and all these things. It just seems to me that in the West, despite all our resources, we just seem to be getting further and further away. And obviously your work very much centralizes around the idea that community health workers, like you said, going to them, and all these subtle and not so subtle signs that it's a human taking care of you can ultimately get us back to a point of health, of what healthcare actually is, and that care word of feeling cared for by another human being, and just how powerful that can be.
Well, I think, James, the reason is it's clunky is because apps were not designed to connect us, even though that's how they're advertised. They were designed to disintermediate us,
Mm,
right? Like that is where the money is made. It's, I need my dog walker like
mm,
to link up with James. Um, but the app does everything it possibly can to make sure that I don't just get to know James and call him up when I need my dog walked or when he needs help, putting up a ladder. It does everything it possibly can so that you keep that interaction
mm.
on the app through them, so such that it can be monetized. So I think there is an inherent tension between these promises. I mean, just speaking very frankly, of building community when the business model is actually to disintermediate
Mm,
community.
mm. So after the HIV activism, you obviously at some point down the line go on to create CRJC, and around a lot of these themes, you're going to build a heck of a lot of work that wins you a heck of a lot of awards and things. So how plot that path for me from this activism to becoming a founder and a CEO.
Yeah, so we're in Liberia, and I think it was one of those things where, as we're trying to make this case to the Ministry of Health about all these things these community networks can do, right? You start to consult the evidence, and it turns out there's just heaps of randomized control trials, so like very rigorous studies on all the different types of care that community health workers, your neighbors with very basic training, delivering care in the home can provide everything from like birth control injections to obviously HIV care management. And it was sort of astonishing because I started to learn the history of community health. Community health workers have been around for about like 100 years. There have been waves of enthusiasm about community healthcare workers over that time. A lot of folks got excited in the 1950s about the barefoot doctors in China. That was kind of like one of the first major national famous programs. There was a big important global health conference in the 1970s in Alma Ata, where basically the concept of primary healthcare was first defined. And a lot of countries responded to that by rolling out, again, national community health worker programs to bring primary healthcare to the people. And then there was another wave of enthusiasm around community health workers in the 2000s related to the explosion of HIV cases and this idea of task shifting, right? How do we, doctors are overwhelmed, nurses are overwhelmed. How do we get people with less training, more of them to do tasks that don't require an MD to do. And yet, through all of these waves, what you saw was that the national programs did not achieve the effects on the number of deaths
Hmm.
or the amount of sickness, on mortality and morbidity that you would expect based on literature. It was like, wow, this literature is like some of the fastest declines in under five mortality of all time ever recorded. Those are driven by community health workers. There are studies about community health workers providing services in war zones and the under five mortality in a war zone in Mali going down, not being held stable, not only going up a little bit, like going down in an active war zone. And so it's like, whoa, why are we not seeing those results at
Mm.
scale? And that became sort of the obsessive question that led to the PhD. Like, what's the secret sauce? What's happening in these trials? This is implementation science question, right? What's happening in these trials that's just not happening in national programs? And I think the really good news was it wasn't some sort of like proprietary thing. It was, it wasn't the secret recipe for Coke. It was really basic stuff. Like the vast majority of community health workers around the world not paid. Out of stock, an average of 1 day out of three.
Right.
Maybe they get training, but it was like 7 years ago. It was a USAID PowerPoint, and that was kind of it. And it's like it doesn't take a rocket scientist or like an MBA, PhD to figure out that if you had a factory and you don't train people and you don't supervise them, you don't supply
Yeah.
them, like what type of product do you think you're gonna get? Like a non-existent one. And
Mm,
that's kind of what healthcare was for so many people who needed it,
mm.
right? It was there on paper, but not there in practice. And so we began to ask the question of like, okay, um, how do we change this? And that was actually when Raj Punjabi, who I used to work with in Liberia, he called me up when I was finishing my PhD, and he was like, "Hey, um, we want to do this thing," and I was like, "Who's we?" And it's like the nonprofits that you compete with for funding. He was the head of a nonprofit that I worked with in Liberia. He's like, "Yeah." I was like, "Cool, what do you wanna do?" And he was like, we don't know." I was like, "Super, where do I sign?" You know, like, what a poison chalice. That was kind of the proto Community Health Impact Coalition. It was a small group of, physicians and community health workers and nonprofits who were delivering frontline care, who many of whom were responsible for the studies that were showing these amazing outlier results, and who were also clear that the pathway to getting these results to everyone was not by like franchising their NGO or continuing to expand. It was, ding dong, the vast majority of care around the world is provided by public systems. So you have to get those public systems to adopt the practices that lead to excellent, cost-effective
Mm,
care. And so how the heck are they supposed to do that, right? They're programmed to be direct delivery orgs, and so how can we figure that out? And that became kind of the animating question, of the coalition. I can
mm.
kind of share more about how we're structured and the levers that we decide what we decide to do together. But yeah, that was
Yeah.
where we
I
started.
definitely would love to know the answers to those questions. The one that I have in mind, though, immediately is what you've described. In my mind, it is this layer of this real ground floor layer. I almost imagine this like healthcare is like a pyramid, and this really is that bottom big thick rung that everything else kind of stands up on because those people are ground floor. They're going direct to people, and it strikes me as just first principles thinking interesting and bizarre in some ways that that level is underappreciated in a public healthcare system by government and is not invested in because perhaps they're not seeing the I mean, I hate talking in healthcare in these terms, but return on the investment in that. Perhaps they're not seeing the results, and so was part of it just illuminating that to governments and the world and going, hold on a minute, guys, like just so you all know, there's people in the community that are doing this job unpaid without any infrastructure around them, any training, but that your whole healthcare is stood up on this. Is in some way was it shining a light on that?
Yeah, absolutely. I think that was the animating question, right? It's like if the vast majority of care is provided by public systems, then what is keeping the public system from adopting this? And you can look at the literature, right? Very effective and also cost effective. Like there's a lot of economic studies around this. We actually just did a big series that summarized the
Mm,
evidence, that you can get these drastic mortality and morbidity declines for something like, $6 per capita. Like this is a rounding error for high income health systems. This is very within reach for even low income health
mm,
systems. And there's been other evidence, generated by other groups that suggests something like a 10 to 1 ROI. All this stuff, just in terms of healthier
mm,
population and the ability to participate in the workforce, et cetera, et cetera. So, like, what's holding people
mm.
back? And that's, I think, when people hear we so the Community Health Impact Coalition, right, is often described as a field catalyst or a systems change organization, systems orchestrator. People are like, what the heck do any of those terms mean? Eyes are glazing over. And the thing we just like to explain it in one sentence. We say, we look at what are the conditions that are holding the problem in place. So it's like, okay, all this evidence seems like a great idea, and yet ministers of health are not moving.
Yeah,
It's not because they woke. It's not because they woke up this morning with malice in their hearts, like
of
I want to
course.
kill children. That's not the answer. They're facing some sort of constraints. Like let's map those constraints and remove those constraints. If you change the game, the players will change. Like we know this, right? So for us, we kind of mapped three constraints. One sounds very boring and technical, but it was guidelines. So, World Health Organization, Africa CDC, all this normative guidance entities had actually at the time that we started, this was back in like 2017, 16, 17, never published a guideline on how do you do community health. It's just like astonishing. It's we're like, okay, yeah, no kidding. Like, who wants to go out on a limb? Let's make sure there's a playbook that says this is what good looks like. Here's how you get it. And like, this is not some crazy idea. This has gone through the whole, you know, Cochrane review, very prescribed WHO
Yeah,
process with lots of checks and balances to make sure it's evidence based and going to produce a good return for you. And then you basically have a, you know, part of it, like a cover your behind when like when you go to do this. You don't have to. be some trailblazing person. You're just following a bog standard playbook. So that was kind of first order of business. It was like, hey, let's get a guideline in place, and that got published in 2018. And it was like, yeah, it's the basic stuff. It's like, yeah, if you someone just has to say, hey, if you're planning community health, uh, uh, national program, you probably want to figure out the supply chain. You probably want to
Yeah.
figure out the supervision. Here are best practices. Here's how others have done this.
Just a stupid question on this, Madeline. So who is that exactly is that aimed at, and to read it? Is that the office of the health minister of that country? Is it that sort of level that you're going in at and going, this is a full playbook for this with everything mapped out?
Yeah, pretty much. Basically, most countries have health plans, right? Or even or health strategies, and they're 5 years, 10 years, maybe 15 years long, and it kind of maps out. Okay, like how are we
Yeah, okay.
deploying our health
Yeah,
workforce
sure.
and all this stuff? And so this is kind of like, hey, you're missing a chapter. It's
Ah,
and
got
and
you.
here's the pieces. So when you're doing your supply chain forecasting, like recall the people that are in the community that in Rwanda are treating like 67% of the malaria cases right at the doorstep. Like if that's not part of your supply chain forecasting, you're going to have a problem. And even more upstream than that, like, hey, there's all these people who are maybe providing care in these pilots, whatnot. How about we make a just like you have a facility master list in a country of all the health facilities, let's make a community health worker master list so you understand who's where, what have they been trained on, what services are they providing, how are they getting supervised, and how critically are the data of those patient encounters being fed back into your HMIS, like your national data system, so you can be tracking everything from outbreaks to
Got you.
vaccination rates and
Understood.
all the things that ministries care about. Yeah, so that was one. The second one is to no one's surprise, financing.
Yeah.
Right, there's a great ROI on this, but the startup costs uh, can be intimidating, right? Because you're adding a whole new workforce into the health system. You got to recruit them, you got to train them, etc. The running costs much more manageable. Those startup costs are high,
Mm,
so we do advocacy to create financing mechanisms like matching funds for ministries of health. A good example is the Africa Frontline First Catalytic Fund that we launched, and it was kind of like one of the first funds that, as countries were applying, I mentioned the Global Fund earlier, for money from these global health institutions or even from multilateral development
mm,
banks, etc. Can we be saying, hey, there's money available to make this transition, like to help you start to do the thing that's going to be good. So that was two. Those are kind of enabling conditions, and then the third was really this has got to be urgent now, here, today. By which I mean health is not just technical; it's also political. The health minister is a politician. There are civil servants, but they're responding to ideally what people demand. And I think historically, community health workers, if you're asking like, what why hasn't this been done? It's they haven't been a relevant constituency. When people think of healthcare, they're like, oh, what do the doctors think? What do the nurses think? No one ever is like even necessarily knows who a community health worker is or asks what they think or could name one.
mm,
Everyone's like, oh, Florence Nightingale, a nurse. It's like, can you name a single community health worker? Most people probably not
mm.
today, but that's kind of part of what we're changing. Like in 5 years, the answer will be, yeah, you can name the head of the Community Health Worker Association in
Ah,
Kenya,
nice.
in Haiti, in Liberia, because they're famous, they're out there on global stages, regional stages, and of course part of national
Mm,
policy processes as well. So activating that in-country networks of community health workers, of NGOs who already tend to get invited to these policy processes, and make sure they're opening the door and say, hey, nothing about community health workers without community health workers. Let's make sure that they're at the table, and then let's use that same surround sound that helped us win certain um, and make sure certain recommendations ended up in the WHO guideline. Let's use that same surround sound approach to
mm,
own these policy processes. So we actually, as a collective, maintain a map of about 100 countries, and we look at when are their health policies expiring. If they're not, we say pro CHW, so professional CHW. If
mm,
community health workers under that policy are not salaried, skilled, supervised, supplied, we use this for very basic 4S framework, then that's an opportunity to flip that country. And we kind of spend 24 months like in the lead up
wow.
to that policy process, activating, making sure that that country's on the list for the financing matching funding, making sure that that Minister of Health is in rooms at the UN General Assembly or the World Health Assembly with ministers that have already done this, sees that it's aspirational, sees that it's like a legacy
I
project in a box,
see.
make sure that the CHW's voice is loud. And this is how we start to get momentum around changing the policy. Again, not just in one district when NGO is working, but across the whole
Hmm.
country through the system that's actually that is the ones that fundamentally confer rights. If you think about health as a right, who confers right? Not an NGO, that's the government. But then two, who are operating at the biggest scale.
It's really interesting because one of the things in your introduction that I saw you smile at was when when I mentioned that one of the most innovative things you can do is change policy or get policy changed. I think what you've alluded to there is so relevant to the people listening that accept a status quo or have a technology that they think could be impactful but run up against policy as a barrier, or are in a position where if policy were to change in their favor, they could make a lot of impact with what they're doing. Could you, I mean, you've outlined a few things there in terms of the messiness of actually how you get policy changed. People talk about lobbying a lot, which, is one single term for a heck of a lot of activity that actually goes and gets things done. How difficult is it to change policy? And you're doing it at that really highest level. And what would your advice be to people that perhaps do want to get policy change? And actually, I have just a small anecdote on this because I had some friends visit for the weekend from medical school. Actually, they're consultants and fully qualified and everything now, which is very bizarre. But one of my friends is a GP, and she it's very bizarre. One of my one of my friends, she was saying as a GP, she was saying as part of their new contract in general practice, they have to be seen to be looking at AI stuff. And as a result of that being
Hmm.
policy for them, they've ended up bringing
Yeah.
in one of the ambient scribes and an AI triage platform and just because they were sort of told as part of policy they had to look at it. And now we're seeing this tech innovation because of it and all these things. And people forget that actually one of the most innovative things you can do is change policy for what it can do downstream. And so I think my question on my call here is to kind of inspire people to change policy, but how difficult is it and what can you get done through doing that and what have you got done through doing that?
I love that anecdote, James, because I think it illustrates a very simple point, which is that things fundamentally do not change because people care.
100%. I
They change because
totally
the
agree.
rules change. They
I
change
totally
because the
agree.
rules change. And so it's like you gotta change the rules.
Yeah.
And so that's the end game. And our and then it's not just like the paper tiger, right? You have to change the rules in a resilient way. You can't force through a policy that's immediately going to get overturned because everybody hates it, right? So it's not just about that policy win, it's about genuinely bringing building the deep it's about organizing. It's about building the community and shifting the Overton window, which is a political science term for what people sense of what is possible is. And I think we've done that in community health. Like when we published our first report back in like 2017, and we called for community health workers to again be salaried, skilled, supervised, supplied. James, people were like read the report and they wrote to us and they're like, "This is like the convertible of healthcare. You people are crazy. This is like some Paul Farmer, like
Wow.
ludicrous
Wow.
nonsense, like so dismissive."
Wow.
And now it's like people are just like, "Oh, it's the car. Like it's just the
Yeah.
car. It's not the convertible. It's just what's required to provide a very basic, level of service. It's or rather any service whatsoever. Like if you don't have all the pieces of this value chain working in concert, then you might as well just be lighting your money on fire, right? Because you're getting zero return because you're not at that minimum threshold of competence to get any return on the investment you're making in people's health. Um, so I think anyway, that is point number one, right? I think a lot of people, or often, there is this sense that we should be going to where the conditions are positive. And I think if you're an individual company, that makes a lot of sense. Like go work with um don't go work with the shoulds, work with the coulds and woulds. But I think if you're concerned about maximum uptake, or you're concerned about equity, or if you really just, you're from the UK and you really want things changed in the UK, I think a really inspiring first place to start is that the coulds and woulds um, are dynamic, not fixed. People's desires are elastic. I mean, if you told somebody in 1985 that they would one day spend $1,000 on a cell phone, they'd be like, "Are
Yeah,
you out of your damn
such a
your
good
mind?"
point.
Like, or in the early 2000s, it's like this Nokia thing. Like, no, I think we'll probably stay at 85. Thank you. And yet, like, we're testing the limits of the elasticity for cell phones. Um, and so I think the identifying places where there are the conditions in place for change, like that's the destination, not the starting point of our shared work, right? It's that actually let's accompany um ministers and give them a sense of, connect them with something that inspires
Mm,
them, with people who can bring their vision
mm,
to
mm.
life. Um, let's activate community health workers and connect them with not just a neighboring community health worker, but with the whole history that they're part of, a whole sense of the profession
Yeah,
that they are part of. A whole, like, a team that is fighting and winning in countries
it's
next door
pride,
and
isn't
gives
it?
you hope that you
Mm,
will win in your, and it's community. I think fundamentally it's about uh connecting to the mission and connecting to each other, that we're moving down the field together. So yeah, I mean there are tactics about, like, okay, we have to this financing mechanism and make sure this guidelines in place and, like, hit the timing. You're not going to go pitch somebody about changing their health policy after they've just written it, right?
yes,
Like, it
sure,
has
sure,
to be
sure,
at
sure,
the
sure,
moment that it's up for review. Like,
sure.
there are a bunch of
Interesting.
tactical things, but fundamentally, um, yeah, it's really about having the vision that we're moving from projects to permanence, and we're not doing it by launching new programs. We're doing it by altering the rules that govern the energy that already exists in the system.
I want to zoom in on the community health workers themselves and the exact work that they're doing, and particularly around technology and something that you and I have talked about before, which is data as well. But before I do, I mean, just to round this off, that what we've talked about at this very high, country level, government level policy and lobbying, what countries or a country does this really well? And have you got a story of a country that perhaps wasn't doing this, and then because of the work you're doing, is now doing this and is now reaping the rewards of doing it?
So I think if you looked, so we have this map, right, that I
Yeah.
mentioned, where we're looking at the policies of all the countries, trying to identify opportunities. That's a public map. If you Google pro CHW dashboard, pro CHW policy dashboard, it's going to be the first hit on Google. And that's an important map because it's both a scoreboard for the movement, right? Like, how is policy changing across the world over time? And our strategic plan, right? Where are we going next? What are the opportunities that are arising? If that map had existed in the early 2000s, like, there would have been a handful of countries on it, right? Ethiopia, Brazil. These are some old established programs where there's a national community health worker program, and the community health workers are actually resourced to perform. I think this is a lot of times, like, some of the confusion. People are like, oh man, community health workers, so cool, silver bullet. And it's like, no, like, community health workers are not magic. They're mirrors. They are, they perform at the level of the resource. That's the fundamental insight. Let's make sure that's being done. If you look at that map today, uh, there's 40, 50 countries that are paying and accrediting community health workers as part of a national system. So there's been a real sea change in the number of countries. And if you want to take a really recent example of a country that's done this, that we were involved in as a coalition, as a collective, it's Kenya. And so we um, let's look at it from through the lens of these tactics, right? Research change guidelines, advocacy change funding, and activating in country networks that ultimately win the policy. So step one was obviously making clear what good looks like. The government actually used a tool, a tool called CHW AIM. That's a bit inside baseball, but anyway, this tool that assesses the state of community health delivery and then suggests possible missing pieces. And so that the government actually mapped its community health workforce using that global tool that we helped instigate and co-designed. Um, the country was eligible for one of these global matching funds, the Africa Fund, the first catalytic fund, among others, that we had co-launched. And then finally, because we had anticipated, hey, there's an election coming up, this health policy is going to be revised.
Ah.
Thousands of community health workers who we trained, and interestingly, we trained them. This is a technology application, not just for health provision, but also for organizing for policy change through this app called CHW Advocates. CHWadvocates.app is that you can go. It's a web-based app. You can go on it on your phone. You type in your phone number, and you basically start learning as a CHW about the profession, about advocacy, and then when you join, you get connected to somebody that's kind of in your neighborhood, in your area that says, hey, do you want to join a call with us? Do you want to join the National Association? There isn't a National Association. Let's start one together. Tell your friends, like each one, tell one is what Margaret Odera, the head of the National Association in Kenya, always says. And so anyway, at this, like we had kind of, there were zero. And then, by the time of this policy moment, there were thousands of CHWs who trained in advocacy. They had already put in the paperwork to register a national association. They wrote a memorandum to Parliament. They spoke to the press. They met the health committee chair. They made sure the priorities of community health workers were heard. And the result is the 2023 Primary Healthcare Act, which actually guarantees pay, insurance, equipment for the 100,000 community health workers nationwide of Kenya. And so um, this has been very cool, both because it illustrates what's possible to like create the momentum to change a policy, but then also because I think this is where advocacy or advocates sometimes make the mistake of thinking like once you win, you've won. And it's like, no, once you win, you get to then like defend, right? And so it's also, I was part of the national policy change when I was living in Liberia, like with that work that I was describing at the top of the podcast. That was all being done by volunteer community health workers, and we kind of had the ministry give us permission to say, like, what if we treated them like the professionals they are? How might health outcomes change? And that pilot ultimately went on post Ebola at the Minister of Health made that kind of professional CHW policy a nationwide thing. And she actually then later served on the board of CHIC when we started to take this worldwide. But unlike in Liberia, in Kenya, I think that the bottom up organizing and activation of networks of community health workers was essential not just to win, but also to perfect the policy. I think we all know that when policy changes, particularly nationwide, it's going to be a bumpy road. We're going to endeavor that it is smooth. But I mean, like, look at Obamacare. It's like they passed the policy 5 years later. They put up a website and it crashed. Like it's really hard to do things on a national scale, and it's no different in any other country, particularly ones that have way fewer resources than the U.S. But having this network of community health workers almost was like the canary in the coal mine, or sort of a real-time live dashboard. So like there would be an announcement, okay, the supplies are going out, or okay, we're sending out the first stipends, and then boom, like this county would just light up and say, hey, actually we never received any backpacks, and there was almost this real-time feedback loop. Whereas in Liberia, one of the things that happened when community health workers were professionalized, and this sometimes happens. Um, this is a broader phenomenon than just community health, but all of the women that had been providing care for years for free got replaced with with teenage men. um, and
Wow.
because there was not an organized voice at that moment for community health workers in Liberia, that kind of happened. And then the ministry sort of only realized it, and to their credit, like a couple of years in, and then they published extensively on it. They were like, "Hey, this is probably a mistake. We're losing a lot of
Wow.
um, the trust, the knowledge. Like
Yeah.
this is not how these transitions should go. This is not a just transition." And so here are some things. If you have to go to womenschws.org, it's the results of that research, just the recommendations for how ministries can make sure that when they do professionalize this workforce, they're bringing in the folks that were involved in some informal way in this care, and prioritizing them, and that it usually ends up being about 70% um, women. So, anyways, but I think the difference between uh, uh, or the importance of not just these top-down enabling conditions, but this bottom-up demand and also feedback and engagement. This is the difference between a policy that
Mm.
um, is really entrenched,
Mm.
um, versus one that's a little bit more fragile. And I mean, to Liberia's credit, again, I think it's becomes more robust, and it's routinely held up as an exemplar of what's possible
Mm.
worldwide with community health workers. But we had the permanent secretary of Kenya at an event at UNGA this autumn, the UN General Assembly. And as many might be aware, it's been a rocky road for anybody in health or development. The just complete shutting off of U.S. foreign aid from one day to the next
Mm.
created a lot of chaos, particularly because if you look at most low and middle income national health budgets, a very sizable portion of that is coming from foreign aid, and maybe it's 20%, maybe it's 30%. It's not all US money, but again, like, it's just most companies could not survive just like a one day to the next absolute slash in revenue. And so this was a moment where I think governments had every excuse to say, "Oh, we're putting this on pause. We're taking a step back. This is not the moment." And actually, what we heard them say very clearly was, "No, we are never going back." And we already see the benefits of this, and I think that's been very heartening to see that you used to have $10 to spend on health, now you have seven, but you should still spend one on this,
Yeah.
right? Because the value's there, and the momentum's there. People are seeing
Wow.
the difference that it's making. So I think that to me is like, okay, there's a real resilience and depth in this movement. It's not just a paper
Mm.
tiger.
Absolutely. And when a country is doing this, and despite ludicrous moves by other administrations to remove financing, etc., they are still doing it. They obviously want to empower those community health workers as much as possible to do as good of a job as possible. And so I'd like to give our audience here a view of what a community health worker's day might look like, the average and perhaps the extreme. And then for us to talk about the technology that can help them do their job and what that looks like. Because, like I've talked about many times on this podcast, there are various frontiers, I think, in health tech that are being pushed at any one time. There's the technological frontier where you might argue that things like quantum and stuff are being pushed. There's definitely an adoption frontier in, for example, UK secondary care. What do hospitals adopt? And we're trying to push that frontier. But there's a frontier that we're talking about here in um, community health workers and what they are being armed with and what they can do to make their job easier, better, and provide data and infrastructure that's perhaps not there in a workforce of people that I imagine around the world globally are paper based. They're probably not opening ChatGPT, although you might actually, the AI conversation at that layer might be interesting to talk about and how that's permeating. But um, let's start with a community health worker and what their day and week looks like and where technology might fit into their job and where you think we're going with that to kind of bolster that workforce.
I'll just say to start that community health workers are in every country around the world, right? And so the experience,
Of
differs.
course.
I'm speaking to you here from, we're in London. There's a community health worker pilot down the street in Westminster that's happening right now. I'll talk about the day of a life of a community health worker in Liberia, but I think this is sometimes a misconception people have, like, oh, it's about, malaria in the
Mm.
Liberian rainforest. It's like, well, first of all, no, it's about all of our health, right? Because of pandemics and health workers often being on the front lines of identifying those outbreaks, whether it's Ebola or otherwise, and containing them. But also that fundamentally, this we can speak on trust and some of the secret sauce of community care provision afterwards. But like that is those patterns play out all over the world. But let's just say, okay, this is it's after sunrise. in Grand Chita County. That's where I used to live in Liberia. This is just on the border with Cote d'Ivoire. Um, we have a community health worker. Let's call her Miriam. She wakes up. She probably checks her phone before heading out. This is something like a basic Android smartphone. Maybe it was solar charged overnight. Liberia is a particularly challenging context because they're, I mean, even in the capital, there's a very small power grid. But that phone has probably an app. Maybe it's Community Health Toolkit, ComCare. There's a bunch of different um, uh, community health based apps that national governments
Mm,
use. But it would guide her through household visits and kind of say, "Hey, who should I visit? Who have I not seen in the past month or whatever?" And there would be some sort of electronic health record on that phone, which in an ideal world is linked again to like
nice.
a national system. And that phone, again, if there is connectivity, it would be just beaming that information up right away. If there's not connectivity, we've seen Liberia was really great at pioneering Bluetooth based systems. So when a supervisor would come, they would just Bluetooth it, grab the data, and off they'd go. There's also a world in which, we really have frequent connectivity issues, and so we carry a paper register as a backup because connectivity is patchy and there's still redundancy. But, somewhere on that spectrum is what's happening. So she does that before she heads out. She grabs her medicine kit, and this has everything from like malaria rapid diagnostic tests to the ACT, the drugs for malaria, oral rehydration salts, zinc, anything that pregnancy tests, things that might come up over the course of the day. And she's probably visiting a house first with, a mother and a child. That child's has had a fever maybe since the previous night. So she would that like I think a lot of the care that community health workers provide is just simple decision trees. Like if a
Mm,
fever, step one would be test for malaria. If the fever, then test the fever. Take the temperature. If it's actually a fever, if it's over, then you would do the malaria diagnostic test. And this is just it's a finger
mm.
prick test. You take a little blood sample, you toss it in a thing that kind of everyone knows what a COVID test look like. It's very very similar. Looks very similar. And then yeah, if it's positive, like she would start treatment actually on the spot. Maybe she checks the child's breathing with a timer to rule out pneumonia. And then she kind of says, okay, I'll be back in like 2 days just to see 48 hours, 72 hours to see how things are going. And she just kind of keeps doing that. So she walks to the next cluster of homes. And again, the frequencies and the distances, like it really depends on the epidemiology, what type of services community health workers are providing, if you're in an urban area versus a rural area. But pretty much uh, every household that she visits, either doing some sort of preventive or curative or promotive care. And then she might even at some point, like, I don't know, stop for lunch. Let's say we're lucky, it's mango season. You're under the tree, you're chomping on some mangoes. Maybe there's a health talk, maybe there's a women's group
Mm.
meeting, maybe and because again, we know that I mean, honestly, like even without a community health worker, like just women meeting makes kids healthier. So like this is to your point about
Wow.
community. There's amazing
Huh,
literature about self-help groups, but with the addition of like,
of
drugs and a
course.
connection to the central health system also supercharges that. Um, and then, yeah, maybe she's visited, let's say that day by her supervisor, right? And that supervisor might observe her providing direct care, would maybe go through records with her, look at whether the amount of malaria or whatever that she's treating is in line with what you'd expect epidemiologically, provide some coaching, provide some correction, maybe do the Bluetooth sync, maybe even do a spot check with community members that she's supposed to have treated and ask them questions. Um, and and then sometime, yeah, and then by the end of the day, she's back at home. She's charging the phone again, solar power bank. Um, Maybe the data's uploading, and then that data ultimately becomes part of ideally, right, a national dashboard that policymakers see, that decision makers are seeing, and that is also beamed back to her, so she can be seeing again, what's her error rate, what type of uh, how many visits, what households like haven't been, she hasn't seen
Mm.
in a while, and off she goes. So yeah, I think you have like diagnostic tech, you have data and reporting tech, like communication, some sort of power connectivity tech, all sorts of different applications throughout the day. And then who knows? Actually, I should say maybe then she also logs on with her phone and joins the Community Health Impact Coalition Activate to Active meeting where she's kind of connecting with other members, the national health system leaders from the national health system in Haiti, leaders from the National Health CHW Association in Uganda, and trading notes about some sort of upcoming um, policy or influence opportunity. So yeah, and there you would have technology again for transnational connection, advocacy, engagement, and maybe she WhatsApps a friend in a neighboring village. The CHW Advocates app brings in someone else to the movement. So a lot of different applications.
They're they're actually really tech enabled. Is the
Yeah.
first thing that comes to mind here, because actually, I, on some level, I was expecting you to say a lot of this is paper based, and but I imagine that's part of the work that you guys do is going in and changing that, right?
Yeah, I mean, certainly the order of the day 5, 10 years ago is these giant registers that
Yeah.
you have to carry, and they're quite heavy. And then you have to bring those registers to the clinic, and then data entry people, on and on. But you see, actually, most countries at this point who are transitioning to
Mm,
professional CHW national programs, the Android phone, like the
mm,
digital, is baked right in,
mm,
like from the get
mm.
go. So when Kenya did this, for instance, yeah, it's like everybody gets a phone, and
Phew.
there's a community health information system that is connected to a HMIS, and again, not without difficulties. Like the Kenya HMIS was like offline for a good chunk of the year earlier
Mm.
this year, and so hence like it's I don't want to paint like a super rosy picture. At the same time, I think a lot of high income countries would be like, "Wow,
What?
real,
I'm sat here
yeah,
going like, hold on a
electronic."
minute, I need like
Yeah,
Liberia sounds interesting like that. Okay.
like
Um,
why can't I log into the NHS
well,
app? Like
this
so
quite.
there is actually um yeah, a lot of really thoughtful
Yeah.
like again national
Yeah, yeah,
scale
yeah.
tech applications in many
The
countries.
other
Yeah.
thing that really sticks out in what you've just described as well is that so much of it, if not all of it, is about the flow of information, and whether tech enabled or not, whether it's a human to human interaction and they're going through a decision tree, and that whether they're documenting that and beaming it hit to someone that then responds technologically or comes in person. So much of this is a really interesting mix of the flow of information, data and information going into people, but then also enabling people to connect with people. It seems like this really, I'm not going to say nice balance, it's a balance. It's a balance of all of that that I imagine is being worked out, and best practices of this are being figured out. And I just think it's really fascinating, I think, with how that parallels with what we're trying to do. And you mentioned this community health workers in London. It'd be really interesting to figure out how they're doing that in London, actually. But it mirrors really well with almost just how our healthcare system is trying to figure out where we put technology and humans as well. Because on some level, on a big level, in fact, the preventative healthcare conversation here in the UK, I mean, we've got preventative healthcare being done by YouTube influencers that have got a medical degree that are just taking it upon themselves to educate the public. And that's the flow of information through technology to them.
Shout out to Dr.
Well, James
O'Donovan.
O'Donovan, quite
Yeah,
absolutely.
yeah.
I mean, he's got what, half a million, more
YouTube
than
day of
half a million
tonight.
followers now, and
Yeah.
he's
Uh,
deploying all of that
Yeah.
information. And YouTube's found a business model for it, and there's ROI for it. I mean, he just does it for the love of it, doesn't he? I mean, he just absolutely loves the impact. Um, but it's just so interesting to me that there's this really interesting balance between technology and human to humans, but all of it is around maximizing the flow of good information at the most efficient possible, I guess, cost of doing so and way of doing so. I just think that's, I don't know if that resonates, but that's what I'm getting from your story anyway.
Yeah, I think it's been very interesting. Actually, I spent some time earlier or last month out in California, and I was meeting with a number of people kind of on the bleeding edge of AI. And I was really struck, right? Like, we're living in a world right now where, like, y- as the American Surgeon General said, loneliness
Yeah.
kills like a pack a day cigarette
Yeah.
habit, right? And yet we're just fundamentally obsessed with making machines faster rather than people closer.
Mm,
And if you zoom out, like, we're just living in this moment of like rising conflict, of like deep fakes, post truth,
mm,
like we just an absolute cratering of trust. Loneliness is surging, antisocial behavior is surging. um, and again, we just keep returning to this question of like efficiency, efficiency, opt out, efficiency. And it's like, I think we should be returning to the question of woo, connection, right? Like, if we optimize for speed, and I think the Western highly industrialized world bears this out, we get a sicker, lonelier world. If we optimize for connection, we get a healthier one. And so, could we not use that perhaps as a framework for how we think about technology, right? Like, you mentioned your clinician friends. It's like if AI can help them reclaim hours from like discharge letters and data entry, and so they can actually just look patients in the eye when they walk into the consultation room, like that is not automation. That is a form of restoration, both for the clinician and for the patient. Because I think fundamentally, like at its core, what is care? What is healthcare? It's an act of it's an act of love. And love, famously, gloriously inefficient. You're not just like, what's the minimum number, viable times I have to tell my wife that I love her before she leaves me. Like, that's not how people think. Like, that's not how it's like, no, how can I just overflow love and care onto this why? Because I love them.
mm,
So time, presence, listening, like all these things that we've built these systems that call those things
mm.
waste, when actually they're the things that make us human, and technology is offering us the opportunity to either dispense with them entirely, which I think would be a big mistake, or to actually finally create the time to do
Yeah.
them. And that to me feels like the opportunity of our time. Let us use technology to connect. And I think that's why we champion community health workers, right? They're the embodiment of real connection. They
Yes.
deserve technology that supports them. And so the goal is not so much, and this is not anti-efficiency. It's not the goal isn't, you know,
But efficiency
let's
is in
dispense with it.
service
It's
of
more
connection, not the other way
efficiency.
around. Yeah,
Precisely.
no, I,
Yeah.
I,
Like
I
that to
totally
me
hear you.
is a future worth
And but
building.
here's the other problem with the system that I notice over here that is in slight contradiction of that, which is that if we don't create that time, that desire for love and care and time will be exploited. And that's the workforce issue that we have currently, is that's what I think hugely, that's what people feel, is that the expectations on their time have never been higher,
Yeah.
and their
Hmm.
expectation to put their love into healthcare remains, and they do. So they end up over
Yeah.
indexing on the amount of time they're in,
Burning out.
and burning out, and this ends up being the problem. How do you combat that with community health worker programs? Do you have self-care as part of this, or is their workload managed? Because I can imagine their patient lists can grow and grow and grow simply as a factor of, as families grow and grow and grow, and communities themselves grow. And so how is that workforce managed in that way?
Yeah, this is a real issue, I'll say. So there are, again, great tools that allow you to model when you're thinking about what is the service package for community health workers, what is the type of care that they're going to deliver versus at the doorstep versus what is the type of care that they're going to refer. And you can easily look at like the epidemiology of a country, or different areas, and say, okay, for doing HIV this and birth control injection that and malaria, then for this many people, it should take you approximately this many hours per week for this many households, plus or minus. And the idea is to try to get that to a reasonable number. I think what we have seen, and this is the tightrope that we walk, right? Part of the way to get community health workers professionalized, to get them treated as the member of the health workforce that they are, is to demonstrate what they can do and to provide more and more complex types of care. For instance, like, oh, community health workers in Malawi provide intramuscular injections. And people are like, wow. And it's like, because if they can do that, then they're definitely professionals and you should definitely pay them and supply them and so on and so forth. But I think the shadow side of that advocacy tactic, though it does create the results and the respect that we want to see, is that then there's a possibility where you're just overloading CHWs with tons of tasks. It's like, oh, and you can do eyeglasses and you can do this and that. And of course, CHWs can do all these things wherever there's a great, there's randomized trials that show the safety, the efficacy, the acceptability of this care being provided by this workforce, then of course they can do it. But obviously you then have to potentially hire more of them, or you make sure that that distribution matches um, the demands on their time. We actually have a paper out in Lancet Global Health on this that looks at time usage versus time contracted. And the conclusion is basically that yeah, in many systems, community health workers, there's fundamental labor exploitation
Yeah.
happening, right? Because the complexity and the time and the it's not adding up. So I think this is something that it is not unique to community health workers. I think a nurse, a doctor, a physician's assistant would all be, as you're
I
saying, like
dread to.
yeah,
They're
they're
never going to do that
overloaded.
study in the NHS. I mean, that's just
Yeah, yeah,
that's just absolute.
right. Well, we've all read This Is Gonna Hurt,
Well,
like it's
quite.
like there's this information is getting out
Mm,
there. And so but then again, like this is the opportunity. We see all this news stories about companies, saving all this money through AI applications and whatnot. And so it's like, okay, great. Like how can we reduce the burden away from the things that direct, because I think the thing about time, right, or about any workforce is that we often have to speak in units of time because that's something that we all understand in the same way. But again, I think research repeatedly shows that it's more about energy management. And so it's like if you were able to say, hey, someone could have an extra 5 minutes on their 5 minute consultation, that would be hugely transformative for them and be potentially a very empowering and energizing 5 minutes for the clinician versus if you replace that 5 minutes with, like, following up on a discharge letter, like, "Woo, energy levels are plummeting and we're much less engaged with our job." But the good news is that, like, yeah, AI could do the second one and potentially create that 5 minutes
yes.
in a cost neutral or cost saving way.
Yes.
Like, I think that, this is really thrilling. But I think it's also worth saying, or sorry, you want to come
No,
in, James?
I just
You have
just
something
to
to
say
say.
it is really thrilling because I've said this 100 times on this podcast, but my friend David Neal, wonderful soundbite, said we're 150 years behind analyzing the value of the human in healthcare because it's always been assumed AI is making us question that. But my thing on this is that if we figure out exactly where to put AI, we can really put the pedal down there and reserve what humans are excellent at to put them there, which gives us a purpose of pushing AI through beyond just efficiency. And if in your framework, which I love, put everything in service of connection, that actually, if we then start to identify the areas that we absolutely want a human to do, because we know that's what perfect healthcare is and what it feels like to the patients, then we can start to
Yeah.
identify, well, definitely human here, definitely AI here, and let's have a conversation about the things in the middle to see what level we want to do at different areas. That brings me to the question that uh, you prompted me to ask you earlier, actually, about what good community care provision looks like, because you mentioned trust. And again, humans build trust with each other. And off the back of building trust, we know, evidence based, better history taking, shorter hospital stay, on a dose dependent relationship with how empathic they feel their clinician is. Like, we know the more empathic they feel their clinician is, more trust, better history, shorter hospital. We know this. It's all there in the evidence. So I've got a feeling that the answer to this question starts to plot this path for us a little bit of what do we reserve for humans and what do we perhaps do with AI. But what does good community care provision look like at its best from CHWs that you've learned?
Yeah, it's interesting. We were just talking about all the possibilities of AI, and yet I think it's important to temper that with um, just as observation that right, like health tech funding, like we're often chasing the
Mm.
shiny, right? We want the dashboards, we want the devices, we want the
Yeah, yeah,
AI
yeah.
models, and obviously all valuable in the ways, potentially valuable in the ways that we've just described. Um, and I think nothing can replace the people who make the system work, like when the Wi-Fi drops, um, because uh, what technology cannot replicate, and we've seen this, is trust, right? Community health workers have cred. Part of the reason they're so effective, and again, this has been shown in study after study, is because community health workers, or pardon me, it's because their communities believe in them.
Mm.
And I think trust is the strongest operating system in healthcare. You cannot code it, you cannot buy it, you cannot deliver it by drone. It's not a product, it's a relationship, and it's one that's fundamentally built before the outbreak, the upgrade, the app. And I think we always want it when it's too late. Like, oh, COVID, like who's going to go convince people to do the
Yeah.
vaccines? And oh gosh, there's the
Interesting.
specter of Ebola, and like da 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 da. And it's like, and yet that's the thing that you can't just summon it.
Mm.
It's gotta be there in a pre-existing way, and so I think fundamentally, if you wanna scale innovation, you have to start by scaling trust. And this is why I would say, AI alone, is not gonna help us fix delivery gaps, and in fact, it might multiply them,
Yeah.
right? I mean, if we think about we were talking about malaria earlier, there's now a malaria vaccine, right? This is thrilling, it's gonna save countless lives, and more than half of kids in Afghanistan are not fully vaccinated,
Mm.
right? Because technology breakthroughs collapse without the people to deliver them. And AI, I think, is a really interesting use case for us because it risks repeating that same pattern, but exponentially faster, right? It's like, oh, AI can surpass doctors in diagnostics. Like, that's amazing. That means that health professionals with less training, maybe like a community health worker, could potentially do more than ever before. But again, let's fast forward to the beginning of this conversation. 86% of community health workers around the world are not
Yes.
salaried. Any given day, they're out of medicines one third of the time. So without actually this, these professional CHWs who are salaried, who are skilled, who are supervised, who are supplied, we're taking this what could potentially be an amazing care delivery network, the world's largest pandemic detection system, and we're just leaving it unplugged, to
Mm.
use a tech metaphor. And so AI, in some senses, is escalating the cost of not supporting community health workers exponentially. And I think there's really good reasons. I mean, just to speak directly to folks who are like, oh, well, let's just ditch the health worker in the first place. I think two observations on that. One, care is not advice, right? Like AI doesn't fundamentally deliver care, right? Right now it delivers advice. And so, and we know we've all gotten a lot of advice in life about exercising, smoking, going to bed, all these things. Um, and it's helpful, but it's not sufficient, right? And if you're thinking about eye burn conditions, like they require a human, a test, a dose, a follow up. So it's like, okay, let's not conflate the two things. Number one, and then number two, yeah, again, like there's an equity question. We're talking about countries that could
Mm.
and should, and elasticity and stuff, and it's like, man, I just mentioned Miriam, CHW in Liberia, who's very tech enabled, but fundamentally, women in low and middle income countries are vastly less likely to
Mm.
use mobile internet. Hundreds of millions of people remain offline. These are precisely the populations that community health workers reach, by the way.
Mm.
And so if you're just going like D to C, your strategy risks widening inequality. And that might not be your problem as a company, but it's certainly our problem as a society, and something that we should be thinking about together. How do we make sure that I think AI plus health workforce um, could finally close the health delivery gap, whereas AI without it risks
Are you
widening it.
optimistic on that? The
I
big sigh perhaps suggests not.
it's one of those things where it's like I believe so strongly in this, and then you're like, but could I be wrong? My sense of where we are,
Mm.
James, is we are surely, again, to circle back to where we started, reaching like peak disintermediation.
Mm.
People are so over, like they just do not want to spend more time in front of a
Yeah.
screen. Their work is in front of the screen. They get therapy, it's in front of
Yeah.
the screen. They, you know, do their banking, it's in front, like all it's just it's too much. And so at what point does the pendulum begin to just swing rapidly back to local, in person, connected, alive, and how are we going to choose to enable that? I feel like that people are craving that. I mean, just the other day, I invited a bunch of people from kind of like the health and media space just to my
Mm,
house for
mm.
dinner, and like some of them I'd met them once, it was women, that's why you weren't invited. But they were they were like second degree, third degree connections, and like just the the yearning and the appetite for like, wow, I'm just gonna come sit down and we're gonna just talk and we're gonna reflect on like the prompt was something around like women who made us. People were telling stories about their sisters, their mothers, their
Oh,
best friends, their
wow.
work, wives and whatnot. And it was
Awesome.
just a beautiful,
Awesome.
completely not tech, you know.
Mm.
I used the technology, I guess, to reach out to them. But and at the end of the dinner, like somebody said, I won't share her name, but she said, "Wow, this really restored my faith in humanity," which sounds like a
Sounds grandiose,
crazy
doesn't it?
thing
But
to
it's
say,
not.
but it's like, actually, if you're just spending all this time in these disintermediate spaces that we know, and I mean, Derek Thompson has written so well about this, that are much more extreme than our in-person interactions. People are sharing, opinions, or opinions are being amplified that are way uh, uh, outside of what the vast majority of people think, that are fundamentally kind of much ruder, um, that are much more skewed towards bad news, and so on and so forth. Like, there's a real cost to
Mm.
just spending so much time in these environments, garbage
Yeah.
in, garbage
Yeah.
out. And so, I think there's a yearning, and people can't maybe articulate what that solution is or what that looks like. That it's like, oh God, it looks like talking to my
Mm.
neighbor. Like, this is not a prescription anyone in the UK wants. but, in jest, but I think there, but there that kernel is in there, and it's like whatever makes us human. Like some alarms going off, and so um can we, I think for those of us having these conversations, like, let's how do we have them
Mm.
at scale with thousands, with
Mm.
millions of people, and decide the type of future that we want to build, and say, hey, we've been running this experiment again, it's making us sad, lonely, sick, like, let's run a different one and still reap, the economic returns and all the things that we all the things that we're concerned about. And I think both is possible.
I love this because it also reminds me of one of the things that I think we need to avoid in healthcare, which is a wealth divide also causing a human robot divide. The wealthy get the humans, and those who aren't get the AI and the robots. And c- off the back of that, we know
Yes.
that care is the currency. We know that connection is the currency. And what I don't want to see is us move to a world where that can be on some level bought and therefore becomes exclusive. I think that's one of the dangers. That it's one of the reasons that conversation like this is actually quite important, because um acknowledging where we can get that connection that is business model positive, that is global health, that is a foundational layer to healthcare in every single country, and figuring out how we put connection front of center and put everything else in service of that. It is just so important that we figure that out and go from there to make sure that we don't head to this world where connection can be bought and then it's something reserved for the wealthy. I think that's, and thank you for bringing that up as well.
Although it's interesting, James, it's just on that point, so we've just moved into a council estate here in
Mm.
London, and we used to live in a neighborhood just 20 minutes away in one of these converted Victorian buildings. And we've only lived here for a couple months. And I know like 15 of my
Mhm.
neighbors in this council estate. And I was looking up, and there's an interesting piece around this. I mean, this is like a contested um you can tell the PhD's still in there, right? So I was
Mhm.
immediately like Googling things. And there's a lot of evidence that folks in lower income brackets actually report stronger local
Yeah.
ties, right? That it's like, and you see this across countries and even within countries. Um, and there's cultural differences too. Like my spouse is from Germany, and everybody's part of a local club, where it's like in I used to live in New York, now we live in London. Everyone has a side hustle because they don't have a local
It's
job,
true. Yeah, it's true.
and they,
It's true.
they they kind of make fun of like the person who goes and like watches the plane land. It's like, oh, how quaint. It's
Mm,
like, well, I don't know, like who's the loser? The one that has hobbies and interests, or the one that has none? Like, like
preach.
what do you
Yeah.
think are so I almost again, I think it's one of those things where I feel like what wealth has done historically is given people the opportunity to opt out, right? Opt out of seeing who cooks your food, of cooking it
Mm,
yourself, of opt out of even grocery shopping and being in the same space as
mm,
as your neighbors. Just get it delivered, like just such an opt out society. And then the folks that can't afford to opt out, like, are in line, they're at the library, they're in like the remnants of these third spaces that we
mm,
still have as community. And so I think it's almost one of those things um where uh my question is, yeah, I think with everything good, there's this stratification risk that you've just described. And it's almost like yeah, I think Miriam knows something about community that
hmm.
a lot of people in there, very wealthy people in their bunkers might do well to rediscover. And what does that look like? So anyway, yeah, that's just a counterpoint, but
Love it.
lots of ways it could go. Anyway,
I
thanks,
love it.
James.
It's been an absolute pleasure. One thing I didn't get to ask you, and I know we've run out of time, was how you guys are funded and if you've got any asks for this community that listen to this podcast. But if you've got an extra 10 seconds to uh, let us know any of that, that would be wonderful to close us out.
Absolutely. Movements are built by many people with many skill sets, so we invite you to join ours. Join CHIC, join chic.org. See how policy change at scale actually happens. See the many people making it work, and contribute. Whatever skill set forms of capital that you have to a healthier world.
Awesome. Madeline, absolute pleasure. Thank you so much for joining me. And I will definitely see you again on this podcast.
Right on, James. Thanks a lot.